Hello and good evening, I'm Melisa Idris.
And I'm Sharaad Kuttan.
You're watching Consider This, the show where we want you to consider and then reconsider what you know of the news of the day. Now, as countries grapple with the COVID-19 pandemic, strong primary healthcare systems can provide a critical first line of defense and response. So primary healthcare is often seen as the first contact someone has with the health system when they have a health issue. And primary healthcare is used to describe everything from a range of healthcare providers who work in the community. Your GP is also a healthcare provider. So joining us on the show tonight to discuss how the COVID-19 pandemic can allow us to build back better our primary healthcare system, we have Dr. Thanussha, Xavier and Dr. Mathen Nair. Both of them are medical doctors. Welcome. It's good to have you both on the show.
Thank you.
Also, both are co-founders of the Malaysian United Democratic Alliance, also known as MUDA. I might just add that, the newly formed political party. If I may begin with a kind of an assessment of how our primary healthcare system performed during the last 6 months of the pandemic, of the MCO. Has that put a strain on the primary healthcare system here in Malaysia, or have we performed well? Thanussha, if I may begin with you.
Yeah, sure. Okay, so firstly, to begin with, I think at a time of great need, I think all of our frontliners and people of Malaysia as well, we rallied together. You know, doctors, the media, even and our Grab food riders and so on, everyone came together. We did the best that we could because it was an unexpected situation. But moving forward, this pandemic looks like it's going to be around for a while, and even when we get past this, there's going to be another one coming at some point in the future. So we kind of need to look towards how we can be better prepared for the next one coming around. And did it expose our deficiencies in the primary healthcare system? Yes, it did, and it's not just Malaysia. Globally, everywhere, everyone scrambled, pooling resources from all over the country, regardless of where they were, trying to do what they can, depending on which region was most affected. Right. So yes, it definitely did.
Mathen, how do you see it in terms of the specific structure that our healthcare system has, and compared to the experiences that you both have had, training in Cuba, a socialist system, but also your experiences in South America, New Zealand, Guyana and such. Could you give us your sense of what those deficiencies are and how we might begin to think through them?
First of all, Sharaad, Melisa, thanks for inviting for the show. And I would like to also extend my heartfelt gratitude to the frontliners, media and all that. Speaking about, in comparison to what we see before this whole COVID-19 pandemic and all the ideas that we get about public health and primary care around globally, we see that whatever we believed before is not what it is right now. Malaysia has not been the only country that has been widely affected with this whole COVID-19. Globally, it's been a show. We see UK revisiting its whole public health system. We see US trying to maneuver its direction towards rethinking its existent or non-existent public health system. We see Prime Minister Xi Jinping, Chinese Prime Minister, saying that more allocation needs to be given, more emphasis needs to be given for primary care, public health and things like that. So this has not only been us, it's everyone. So the deficiencies in Malaysia, structural wise, yes, there has been certain things that has been highlighted. It has always been there. Certain things that have been highlighted would be, if I want to point my finger, would be the primary care network. We didn't have a primary care network at a basic level. When this pandemic came to us, we didn't know, people at primary care level, at community level, did not know where to go. We didn't have certain clinics that was prepared for pandemic. Doctors were not trained to look at it in a certain way. We didn't have a certain alert system that could say, hey, this is how this is A, this is B, and this is C. So this were the fundamental things that I feel that.
If I could get you to explain what you mean by a primary care network and why there was a need for a strengthening of that.
Okay, healthcare. When you look at healthcare, right? Healthcare is something that is very dynamic and it's integral, because healthcare has a certain need that needs to be fulfilled that changes between the demographic of a certain region, socio-cultural aspect of it. governance in the local place, communal literacy, all these plays a certain role in how healthcare needs to be focused on. So a primary care network is needed is because what happens in an urban setting in KL is not the same way you deal with in Gua Musang, Kelantan. And that's not the same way you look at it in Sabah, Sarawak, or different places. Demographic, socio-cultural aspect, communal literacy needs to be an emphasis in primary care. So this network needs to be dynamic, changing, differing on where we are and things like that.
Okay, can we ask them, you know, when you think about it, right, is it been like the way in which healthcare systems are designed? There's a kind of cookie cutter approach, which is that we have a standard template and we apply that to every. Is that been the Malaysian experience, for better or for worse?
Yes.
Okay, but so then what is the challenge of having a more bespoke, a more nuanced, or a site-specific or area-specific, demographic-specific kind of approach? Is it very difficult? Is it very costly? What would stop us from actually going beyond the cookie cutter approach?
Okay, the first answer to that would be simple willpower.
Or political will.
Political willpower, of
Political,
course.
okay, yeah.
I mean, we can suggest all we want, but at the end of the day, it is political willpower that needs to put into effect. And it is definitely needed. We kind of saw that with the COVID-19 pandemic. And when we went on the ground for our jelajah for the political party, and when we went to the East Coast, it was really apparent when we were in Kuantan, and you know, they started saying, "No, healthcare is such a concern over here," because when we go to the hospitals, if it's not an emergency matter, we have to wait up to 12 hours to be seen, and there's just one hospital for all of these residential areas around here. There's not, you know, there's too many people, overcrowding, you know, a dense population. That is the issue, which is probably something similar to what we have here in KL, because it's, you know, city-like structure. Right. And then when we went into areas like, you know, Gua Musang, Dungun, over there it's more of a rural setting. Population is not really an issue. When we ask them about healthcare, they say, no, it's not an issue at all. You know, we don't have to wait much. And I ask them, like, also, do doctors have time to, you know, have mental health awareness campaigns and so on? They say, yes, of course, because there's not many people. They have more time for other initiatives, for health education and so on.
Is it a mismatch between supply and demand? Is it because the information is incorrect, that the supply information and the demand information does not match up?
Exactly, because there's no network. We're not listening to the concerns. For example, the Dungun people, so I say, okay, so then what is the issue here? They say smoking prevalence. So then, from the level of governance, what would your policy approach be for an area like Dungun and Kuantan? Kuantan's issue is like, okay, clear cut, more human resource, healthcare infrastructure. Dungun, that is where you attack your smoking awareness campaign, and etc. So the approach to that, how would you know what to do where? A network. Okay. On the ground.
We're going to take a quick break, but still lots to cover on this topic right here on Consider This. Don't go anywhere. Welcome back to Consider This. I'm Melisa Idris. With me is Sharaad Kuttan. We are speaking to the good doctors Thanussha and Mathen about primary healthcare, how to build back better after the pandemic. Now, Thanussha, just before the break, you talked a little bit about your experiences in Kelantan, what you've noticed about the mismatch between what's being provided in terms of primary healthcare and what is needed by the community. Mathen, I may want to pose this question to you in terms of wondering how do we then look to decentralize that? Is that what is necessary? You talked about political will. Is decentralizing, empowering communities to better tailor what they need in terms of healthcare, is that the solution?
Exactly. Healthcare, like education, needs to have a communal approach. It needs to be decentralized. Policies cannot come up from center, top-down approach. It needs to be grassroots up. Yeah, we need to, because for instance, an infectious disease, yeah, problem, right, is not the same in different demographic. So the approach to infectious disease needs to be tailored to that community setting, because and also doctors need to be more trained to handle certain different communities as well. Speaking to an orang asli is not the same as speaking to an urban setting. An approach to orang asli, due to the accessibility and infrastructure, it will not be the same in an urban setting. So decentralizing would be the best way to move forward, because it will create a network which could also help with other things, like we have not looked at health literacy yet.
That's an interesting point. I want to ask you about that, because when we talk about principles, right, they seem very nice, and when we talk about decentralization, it seems like a very democratic approach. But it also presumes a certain capacity for those on the ground to make decisions and inform decisions. And is that available in our system? So if you were going to take the current system and change it, would you have the kinds of people on the ground able to make the decisions that are necessary?
You mean the medical doctors
Yeah,
themselves?
the medical doctors, but also the community. We're talking about a community approach.
Yeah.
There are people in the community informed enough to actually articulate what is necessary for them.
Correct. So that's where the network comes into play. We start by engaging stakeholders, and by stakeholders, not just the healthcare professionals, the ketua kampung, the teachers in the community, the NGOs, the local activists who know what are the health issues in the community, starting by listening and hearing what they have to say, which is what Muda was aiming to do. I mean, we could have just published a list of the policies we intend to push as a political party overnight and call it like, okay, this is what we're going to do. Why haven't we done it? Because we actually want to listen, not just in terms of healthcare, everything else, education, etc., to champion what actually people want and not take the high ground and assume like, oh, I think I know what you want.
Okay.
Go down there, listen, what matters to them, and then identify what are the common issues nationwide that people feel that needs to be championed.
Can I ask, where does that intersect? Your work with Muda and your, what you hope to achieve through Muda, versus with your passions clearly about primary healthcare, with the vision you have for primary healthcare, Mathen.
Okay, may I just tip off on the question that you asked for, Sharaad, right? It all depends on social advocacy. Yeah, it's something that in the beginning of medicine, this practice of medicine, it was very much highlighted. If you look at the concept of health, health is when mental, social, and physical well-being is in harmony, right? So we are so focused, over-specialized, that we only look at physical as the only aspect of medicine. We forgot about the mental part of it and the social advocacy. Doctors are not advocates anymore. So to answer your question, how do we engage the grassroots people? We start with advocacy. Doctors need to be trained to know that there is this part where there is integral approach to medicine. Doctors in Malaysia and some other countries as well are thought to be over-specialized. The first thing they think of when they come up to university is, what do I specialize in? Because of the education platform. So and to also answer Melisa's question, how do we clear out, where do we draw the line between the party vision and the healthcare vision? As long as we see as we are rakyat-centric, as long as we see the importance is to get the best thing for the rakyat, I don't see there'll be any lines there.
Well, in the intersection, where does that cross your work with Muda and your work as a primary, pushing for a primary healthcare reform?
Yeah.
The way I look at it, pushing our work with Muda and primary healthcare would be the same thing, because we are thinking of building for the rakyat from grassroots up.
Yeah.
So if primary healthcare is going to change a certain dynamics of community setting, that is also what Muda wants. That's what we want to work at.
I think that's what is different with Muda. We don't come in here with our own personal agenda. What is our agenda? Why aren't we working abroad and living a comfortable life? Because we actually want to make a difference. And the difference that we want to make is, of course, what the people want and what would give them a better quality of life. And that is also what Muda wants to champion. So it's, of course, just one and the same. It's not different at all.
I want to say, sometimes when what people want is, a lot of pills or an injection from a doctor, even though the doctor might not think it's necessary, right? Yeah. So people don't always know what they want. I mean, I want to put it out there, but I do want to ask you a question around the issue of medicine is part of the economy? Because that seems to be part of the problem that we have here, right? We have the state with public hospitals, but we also have private provision of healthcare in which the state is involved through GLCs. And does that set up some conflicts of interest? I mean, how do you see that? Is that something that you can work with, the mixed nature of health provision in this country? Or you say that, as a party, that you would advocate for changing of the system in its entirety, based maybe on a state-led healthcare system?
Okay.
Thanussha.
From the stand of for the party, that is definitely something that needs to be discussed together, right? But as far as how we can use both the private and public sector to our benefit would be, for example, in urban areas like KL and so on, when there's a clear need for human resource and infrastructure, which is not something that can be built overnight or even within the year. It costs a lot to build clinics and hospitals and to train medical doctors. So a solution could be public-private partnerships, for example. So that's how we can perhaps bring harmony for both the public and private sector. We can't exclude the private sector completely, but they are an excellent source of human resource and infrastructure ready and waiting in urban areas. So that could be a possible solution.
Are there ideological issues for you, Mathen, around the question of healthcare? Yeah. About, I mean, you both trained in a socialist system.
Coming back is quite different.
Was it something you would advocate, or would you think there's actually there are problems in the Cuban system that can't be applied, or things that are specific to Cuba that cannot be applied elsewhere?
Being a person who likes to experiment things and always being a practitioner of science, when I finished my whole training in Cuba, and when I found this community engagement, community medicine, public health aspect of this, what we are speaking about, I made it a point to go to another different political scene, like South America, where it was more democratic and things like that, to see how this kind of community engagement can be applied there. I made it a point to do that. And then I traveled to one of the biggest democracy in the world, Kerala, spoke to some doctors, worked, did my research. So when we speak about if this is doable and ideologically, yes, definitely. That's the reason why it needs to be done in a way where there is a decentralization. In urban setting, as what Dr. Thanussha said, use the private care facilities that is already there. Use the resources that is already there. The problem is waiting in line. Start with something like NCD, non-communicable disease. Give those private care doctors some work. They're already saying that they don't have enough patients. Empower them. Empowerment is also part of public health.
Okay, I'm really glad you brought up Kerala, and I also want to come back and talk about the different models around the world. We're going to take another quick break, but we'll be back with more, so stay tuned. Thank you so much for staying with us on Consider This. I'm Melisa Idris. With me, Sharaad Kuttan. We're chatting tonight to medical doctors Dr. Thanussha Francis Xavier and Dr. Mathen Nair about building back better our primary healthcare system. Mathen, just before the break, you mentioned Kerala, and I think that's quite interesting because Kerala has consistently been a prominent outlier in terms of better health outcomes when it compared to other states in India. What were some of the things that you observed there that perhaps we might learn here in Malaysia that we can build back better?
One of the most stark thing that I saw that Kerala did that was really caught my eye was that they had a three-layer system. A system that was the stronger system was deeply embedded in the community. They had doctors assigned for a certain number of population, which gave a certain womb to tomb care. Continuity is another part of public health that we need to look at. So this doctors catered for the population, and when there was a certain demand for this communal setting to have a certain complication that needs to be addressed in a bigger setting, in a bigger institution, they were referred accordingly. So there was a transient care and there was a continuous care that I saw in Kerala that I feel that created a strong network that we're coming back at. primary care network once again. So that's one of those things that I saw.
And that's something we can do. I mean, I love the use of womb to tomb. I always think of cradle to grave, but womb to tomb is very
Nice.
good and it rhymes.
Does
Yeah.
nice, sounds nicer.
You too, Thanussha, you've been, have you seen other contexts where, and in Guyana in particular, so tell us about that. I mean, is there something we could take from the Guyanese experience and perhaps, implement here?
The Guyanese system is actually very similar to the Cuban model, and actually that's also very similar to the Kerala model, whereby the healthcare system is divided into 3 tiers and back to the womb to tomb thing. Now, why this is effective is that every single person, well, Guyana is working towards it, but that's the plan. Every single person has a doctor that is responsible for them, who checks up on them. So if you miss your medical appointment or forget to collect your medicine, there's someone who's checking on you, who's responsible for you, who knows that, oh, if you've been diabetic for so long, okay, at this point that I'm going to check on your kidneys and your heart to make sure that, not wait till you go into kidney failure and then be like, okay, dialysis for you. Prevention and promotion of care. How can we encourage things like that here in Malaysia? Is when there's a proper doctor to population ratio, kind of like what exists now in Dungun, when because there's a balance of doctor to population, the doctors have more time, for initiatives to shift towards promotion and prevention of care instead of just curing and waiting for complications and fixing.
We need more doctors, you're saying, more doctors.
See, that's the thing. We actually do have enough doctors. I think we have about 5,000 medical graduates per year. But the problem is that because there isn't enough training hospitals, there's a backlog of doctors, and which is why Dr. Mathen and I are not in the system either. So the human resource is there, but there's a gap. Insufficient infrastructure, but yet there's a demand on the ground for doctors. So there's something here in the middle that needs to be fixed.
In fact, there was, there's been some controversy over the contract system and either insufficient number of contracts, or contracts being too short, so doctors can't specialize and so on and so forth. What are your position on that? Mathen, let's start with you.
I feel this whole backlog, as what Dr. Thanussha was saying, is due to the system again. Yeah. What kind of doctors are we training for? There is certainly a demand for non-communicable disease at primary care setting. What are we doing with these doctors? Why is the training needed to only be in hospital? We could create specialists who could train people to take care of certain communal diseases. We could start thinking of that. And at the same time, another thing that we could also be doing is that how do we work with these contract doctors to give them a certain, probably the housemanship needs to be reduced. Probably infrastructure per se right now that we are looking at needs to be rethought. We need to be rethinking.
Is there a lack of creativity in the rethinking about our system? Is there?
Yes, I would say so. I would say so, because it's contract doctor issues and doctors being backlogged is not something we see now. It's been there for some time. I mean, what is it really stopping from us taking these 5,000 qualified doctors and putting them to certain use that we can certainly make it happen?
So what is stopping us? Is it a budgetary issue?
It's creativity. We're not looking and we're not learning from other models of other nations that they have used it. Other nations like Cuba, for instance, let me talk to you about what I know. They have used these doctors. They have huge amount of human resource there and limited infrastructures to train. How are they using their doctors? The method of training is different. They're making doctors who are more integral, who can adapt to community setting. A doctor who after his hospital training can be in a polyclinic and do his whole training there. Having a certain logbook and having a specialist to oversee it, certain amount of work that can be done in a community setting like prevention, promotion. We need more dynamics and more approach to healthcare. And then training will come.
Okay, quickly, Thanussha, do you have anything to add to that? I mean, do you think we will use the pandemic as an opportunity to act on the lessons that we've learned?
We had better, because again, we're still in this. We don't know if the current COVID-19 pandemic is going to get better or worse globally. And again, even if we do get past this, there's the next one coming right around the corner. It's just the way world is. And yes, there is definitely a lack of creativity and innovation. which is why there's been a call for a new youth-led political party to bring about a fresh way of looking at things. I just have to insert that over there.
I know you had to, yes.
Yeah.
Okay.
So
Well,
for
all
sure.
right. Thank you both for being on the show tonight and helping us, gain some insight into what's happening on the ground and your vision for primary healthcare. Appreciate your time, both of you.
Thank you for having us.
That's all the time we have on this episode of Consider This. I'm Melisa Idris.
And I'm Sharaad Kuttan, signing off for the evening.
Thank you so much for watching. Good night.